Good evening, everybody. We have the pleasure tonight to be together with three esteemed primary authors of three great papers that we picked from the special JSCAI issue on the role of AI in cardiovascular interventions. And we had the pleasure to put together with Dr. Edelman, there as co-editors, a line of many interesting original papers and reviews and viewpoints in the field, three of which are going to be presented by the primary authors tonight. We'll have this opportunity to get a little more to know about these papers and also have some creative discussion, a field that is very evolving, a field that is very exciting, and let's see where things are heading in the years to come. We are going to start with the first paper presented by Dr. Maryam Alsharqi from MIT in Cambridge, in the group of Dr. Edelman. Together, they co-author a paper on a review paper on the role of AI in cardiovascular imaging and interventional cardiology, emerging trends and clinical implications. After this paper, we're going to go to Dr. Shlofmitz, Ivan Shlofmitz, very well known to everybody for his innovative spirit and full of energy. He's going to present their paper, interesting, very fresh review on AI in intravascular imaging for PCI, a new era of precision. He's going to present to us all the latest and in the field of software and hardware in intracoronary imaging. And then finally, we will conclude with the well-known to everybody, Dr. Chamié, Daniel from Yale, who is led a wonderful group, a European and American multi-author effort here on something very interesting, very refreshing as well, a viewpoint on how can artificial imaging capture and quantify the expertise and clinical judgment implications for intracoronary imaging guidance for PCI. So without further delay, let me start with the first paper by Dr. Alsharqi. Welcome to this panel, and we're very excited to hear more about your work.
Thank you for the invitation. It's a pleasure to be here today with you. In our review, the artificial intelligence in cardiovascular imaging and interventional cardiology, we separately discussed the non-interventional and interventional applications of AI, fully aware that these technologies will melt into a comprehensive integrated system in the future. We discussed in depth the clinical use of recent AI applications in non-invasive cardiovascular imaging related to interventional cardiology, potential opportunities, current challenges and implications, as well as considerations for safe implementation in clinical practice. As you know, with the expansion of transcatheter interventions, non-invasive imaging has become essential in guiding and facilitating these procedures, whether using echocardiography and MRI for structural and functional assessment, nuclear imaging for perfusion, or CT for coronary artery assessment. But each of these modalities has proven a unique diagnostic and prognostic value. We all know that multimodality imaging offers more accurate planning and execution of interventional procedures. But the growing volume of images per scan complicates analysis, increasing errors and challenging human interpretation. When it comes to AI, especially deep learning techniques, these methods are capable to address the challenges by performing a high level of image processing and interpretation, reducing a human error, missing diagnoses, and variability. The unique nature of interventional cardiology procedures benefiting from different imaging modalities presents an ideal target for the development of AI. And over the last decade, we've witnessed rapid advancements in AI and imaging that have shown the ability to overcome the lengthy acquisition time in MRI and CT, even reducing the radiation exposure, overcoming imaging artifacts, and minimizing radiation exposure while maintaining interpretable image quality. While interventional cardiology, AI has shifted the current practice by guiding vascular access, optimizing fluoroscopy, viewing angles, and planning procedural strategies. Starting with coronary interventions, one of the main advancements is the AI-derived non-invasive estimation of FFR by 3D reconstruction of coronary arteries, which has shown comparable results with invasive FFR. Also, advancements in automated analysis for stress echocardiography imaging, leading to improvements in the overall sensitivity and specificity of the tests. In this review, we discussed visualization of real-time anatomy during transcatheter valve interventions and how machine learning simulation models can guide in complicated or rarely performed procedures, as well as guiding junior interventionists. We have also covered other AI applications in electrophysiology for patients with AF ablation and in mechanical circulatory support devices for support optimization and improving outcomes. While there is a growing number of AI and machine learning applications claiming superiority to traditional practice, just a few of these applications have yet been progressed to impact the clinical outcomes. And only 24% of the published AI algorithms have been tested on external cohorts. When we train a model on imbalanced data, this leads to unfair or false decisions about underrepresented populations. Nowadays, even with fully automated image quantification, AI-generated outcomes are reviewed and confirmed by clinicians before making clinical decisions. However, in the future, some of these steps are likely to be more autonomous and may evolve to complete a human operator independence. In such instance, who becomes responsible for incorrect quantification causing fatal complications during an intervention? Is it the interventionist or the image specialist or the model developer? So with that, I would like to conclude. We are well beyond the point of whether we should or should not use AI in clinical practice. AI in all its form has been deeply embedded in clinical workflows, particularly in cardiovascular imaging and interventional cardiology. It is only by understanding how AI techniques work that we can harness it for the greater good and avoid uninformed bias or misleading diagnoses.
Thank you so much. That was excellent, very concise, and quite interesting to see how these digital technologies can change the game across the board of imaging, with emphasis here on non-invasive imaging, CT, MRI, and nuclear and echocardiography. So a very quick question, is AI now a friend or foe?
Well, we need to understand how AI works in order to have it as a friend. If we don't understand AI, then we are going to struggle with it.
That's very important. So the tool itself is not necessarily good or bad. It's how we use it in our practice, how we integrate it in our practice, and it's in our hands to make it an ally, an aid, versus something which is going to be disruptive. Excellent. Thank you so much. Let me now kindly pass to the second paper. Dr. Shlofmitz, as I said, very well known from St. Francis in New York, very well engaged in the field of imaging, primarily imaging, OCT, IVUS, right? Ivan, let's hear about your wonderful paper on what's the latest hardware and software in the field of intracoronary imaging.
Thanks so much. Thanks for the kind introduction. And I think just as some background before just jumping into this specific paper, a lot of discussion in the news what's happened with guidelines. So U.S. guidelines now updated for ACS that it's now a Class 1A to use intravascular imaging in your complex patients. And that's a major change from prior guidelines. It now is the same as what we have in Europe with the ESC guidelines. And this now is a recommendation for near universal intravascular imaging in complex patients, at least undergoing ACS in the United States. Now, we know there's a discordance between that and a discrepancy between that and what sort of intravascular imaging use is actually used. In most of the US, it's about 20%. And when you really look at the why, there was a nice paper out of Michigan which showed that one of the biggest predictors of when a patient gets imaging is who the doctor is and what hospital the patient's being treated in. And when we've tried to go back and look at that why aren't physicians with all this data, meta-analyses and randomized trials supporting the benefit for our patients with imaging, it comes down to really an understanding of what we're looking at. The reality is intravascular imaging takes some time to understand and master, and it's not always educated on in fellowship programs. And a few years back, we asked graduating fellows from interventional fellowship programs. We did a basic test to see were they competent in IVUS and OCT, some foundational skills, and only 7% of graduating interventional fellows were able to competently use IVUS or OCT. So if you're graduating without that skill set, you don't end up using that. So I think a big part really comes down to streamlining the process, making it easy to use. And fortunately, there's been major advances over the past 2 years or so with intravascular imaging that's commercially available. And that is really largely thanks to artificial intelligence. And building on what we just heard in the last talk, when we jump inside the vessels and the coronary vessels in the cath lab, very similarly, using that artificial intelligence, it completely changes the way we understand and can utilize intravascular imaging. And I think it really democratizes what physicians can do with it, because you don't need to have worked in an intravascular imaging core lab to now understand what you're looking at, what the plaque type is, what the size of the vessel, and then more importantly, just extracting that information of what to actually do with that information. How do we treat this patient? So a number of companies now have introduced this technology. Just to kind of give an overview of this picture here, we basically saw it in this paper to serve as just a practical review of what's actually available and what sort of information you get, because there are some differences between the different companies. So on the left is an image of the software from Abbott and their OCT system. Just to the right of it is the first IVUS system to integrate artificial intelligence. It's the Boston Scientific's Vigo system, looking at intravascular ultrasound and AI. Just to the right of that is a company called Gentuity and their HFOCT AI. And then all the way on the right is SpectraWaves AI, which utilizes both OCT and near-infrared spectroscopy. So 4 different companies, 4 different types of catheters, all slightly different, but they all have since incorporated artificial intelligence, and it's all for the same concept, basically automated recognition of the vessel size, lumen size. In some cases, you have stent detection. In some cases, you have automated plaque detection, telling the physician they don't need to be an expert in recognizing, is this calcium, is this lipid? It's all color-coded. So with a basic course in 60-minute overview and an instruction, I feel confident we can teach physicians now how to integrate this to their practice. So if they didn't do a year intravascular imaging fellowship or work in an imaging core lab, that they can comfortably incorporate this into their practice so they get all that Class 1A benefit of using intravascular imaging. And ultimately, it's all about getting better PCI results and better long-term results for our patients. And I think just finally, the last step is we all know that we don't get the better outcomes that we see as in the meta-analysis, 50% reduction in death with intravascular imaging. You don't get that from just opening the catheter and inserting it into the body and subjectively looking at it. It's really using the information from the imaging to guide your procedure, which is why they call it imaging-guided PCI. And we need to have an algorithmic approach. And what these AI systems all do with intravascular imaging they incorporate the workflow so that there's an actual workflow. This isn't just open up the IVUS or OCT and get an idea. I think it looks good. We're looking for objective information and getting away from subjective. So we really know when we have an adequate result or if there's an opportunity to further optimize in real time while you're in the cath lab before the patient leaves. So I think this has transformed practice already just in the past 2 years that it's been available. And this is the future of, I believe, imaging-guided PCI. And we're going to hopefully see even more advances in the very near future.
That was great, and hopefully the near future, the immediate future, I would say. So very, very well presented. Very nice summary of the technologies, Ivan, and also thank you for putting together and updating us on the latest in the field of the guidelines. Is a statement that now that the data are in place and fully supportive of the mortality benefit with imaging, plus the guideline also on both sides of the ocean are also in place, plus the software and hardware is also in place, is a statement that now we have no excuse to do PCIs without imaging, correct?
I agree with that statement. I guess the last excuse is just if you don't know what to do with information. And then that's the full circle of that's where AI comes in, because, you know, in the US, the average interventionist does about 1 PCI a week. So it's hard to get that expertise. What do I do in each scenario? And AI makes us a better physician because, you know, you have, you know, like the people on this panel, experts in intravascular imaging, you have that expert in the room with you because the AI is there to tell you, yeah, that, you know, when I think that's calcium, and you have something to back that up. Yeah, this is calcium, or there is underexpansion. There's you know only 50% expansion here. I need to post dilate this, and so I think that really makes it where there's really no excuse. The AI will keep improving, and I think there'll be some additional features in the very near future that will help make our job even easier. And that's what it's all about, is trying to get, as you said, make our patients live longer, feel better, and get better results in the cath lab so that we could hopefully keep them out of the cath lab.
So we need we will have an Ivan Shlofmitz in every cath lab, and this will be the ideal. Thank you so much. Let me pass to the last but not least paper by Daniel Chamié from Yale. Very, very interesting. Different viewpoint, very refreshing viewpoint. Let's pull the paper. Another effort from multiple co-authors from multiple sites on both sides of the Atlantic Ocean. So Daniel, please.
Yeah, thank you, Yiannis, for the kind introduction, and JSCAI for the invitation to participate in this session. And so I'm very grateful to follow Evan. He set the stage for, you know, the work we've done. And actually, this is, as you said, this is a collaborative effort between our group at Yale and, you know, the guys from Imperial College. So it's really a multi-clinician and multi-continent exercise here. With the focus on, you know, we embrace the technological advance that occurred over the last 2 or 3 years in the incorporation of these AI on the commercially available systems, as Evan demonstrated. But at the same time, that we acknowledge that those AI systems, they reduce subjectivity. Now the MLA is automatically detected. The EEM is displayed to you, the vessel size, the lesion length. There's no more subjectivity in, you know, quantifying and determining the lesion length, the vessel size, which improves accuracy and reproducibility. But we have seen, and this might be our biased viewpoint, that these AI advances have benefited more physicians who are using intravascular imaging for a long time and who are used to do all those judgments manually or by applying their visual expertise on the images. We haven't seen, you know, less experienced operators benefiting or using these AI tools to the most. So, which led us to think that, although AI is there to help, it's still up to the operator to make decisions. And they have to integrate all that information and make decisions at the end of the day where to land the stent, and, how to pulse dilate and how big the balloon should be when you have tapered vessels or when you have a side branch. So when we're looking at images, things are not black and white. There are many nuances that we take into consideration when we make decisions. Although we have clear guidelines on consensus documents, like, for example, landing zones. We try to find the near normal vessel references with less plaque burden as possible and avoid lipid plaques, right? But not all cases are made the same. Sometimes you're going to land stents on plaque. There's diffuse disease. The patient is diabetic. There are no normal landing zones. And you still need to make a decision where to land your stent. Simple strategies that might be easier for an experienced operator and less so for the less experienced operator. So that's a long introduction for the work that we're doing. This is prototype, and we made 2 prototypes. The first one, and actually I think Evan mentions this in his paper, is for the AI to be used to the maximum, you need to have good quality images. That's the first step, right? We need to optimize image and acquisition. So we looked into image quality. And in the top panel, you just see multiple different artifacts in imaging that can affect image quality in different ways. But more important than that is on the second row from top to bottom, you'll see that the image quality is affected as a continuum. You might have some artifacts that minimally affect image, and then you can just ignore them. Or you have artifacts that significantly affect image interpretation. And it's still up to the operator to recognize when it's enough that you can use that image or when the artifact is really bad and you should discard that image. This has some implications in the sense that you don't make judgments when there's poor quality image. Or if you think, in a more advanced way, these could be applied in series with the current AI in a manner that once you score images according to the quality, and these qualities below a certain level, AI would never be implemented. So there's not enough image quality. There's not enough information for you to make decisions. So AI would ignore those and flag those cross-sections out for you. And we believe also that this prototype can help train physicians, right? So you can recognize image quality patterns. You have a grading system based on AI, and then you can try to find solutions for the problems and minimize the reoccurrence of those artifacts in the future. So how these work? So we're trying to capture, you said that you would love to have Evan in every cath lab. And I would say that not only Evan, we can have a panel of experts. And that's how we did it. That's a panel of expert opinions. So we just looked at thousands of OCT cross-sections with different types of artifacts. And the machine learned how to score them the same way that the experts were doing, no matter which type of artifacts, how many combinations of artifacts we have, how long they were, whatever. So whenever the expert judged this is a bad quality, the AI now can reproduce. And then the challenge was to try to have machine learning the same way that we think, integrating all those nuanced information and try to output that in a quantifiable index. And that's how we're trying to represent. This might change in the future. This is very prototypical, but you can look in the middle panel. That's a longitudinal OCT pullback. You can see blood in the middle. There's nerve. There's lots of things. And the AI now is learning. So everything that is red is very low quality. Everything that is dark green is very high quality. And then you have the absolute scoring system provided by AI in that gray line on below the color-coded bar. So very low scores are close to 0. When you're closer to 1, that's the best image quality you can have. And then you have just representative cross-sections, with the AI scoring them according to the expert training from the machine. Another application is on the right. So we ask ourselves a simple question: where to land the stent? And as I mentioned, we're looking for the most normal looking vessels with less disease and ideally no lipid plaques. And not always you're going to find a case where you have normal references and a lesion in the middle. You're going to land on tapered vessels, on plaques everywhere, on previous stents with neointima. So there are many different situations. And even when you're landing stents on a plaque, the plaque might be calcific, might be fibrotic, might be lipidic, might be eccentric, might be concentric. So there are so many combinations. But still, when we are in the lab, we kind of integrate all that information and we make decisions, right? So that's what we're training the machine to do. So experts are training the computer to recognize the different patterns. And what we are providing here is an output based on how the experts would select landing zones on this case. So if you look at cross-sections numbers 1, 2, and 8, they indicate very low lumen, lesions with very small lumen areas. Those are 3 serial lesions that we have there. Potential land zones would be number 7. From distal to proximal would be number 7 to number 5, where we have near normal references, and the AI scored them very high. Then for the middle lesion, we could use cross-section number 6 to number 3 or 4, or just do an overlapping stent from 5 to 3, or just do one long stent from 7 to 3, right? So there are many options, and each operator might be doing that different. So where we are at the moment, we are training the machine to recognize areas that experts judge as the best landing zones that you have in that particular case. The next step will be, now we can assemble a group of experts and say, okay, if you have a situation like this, how would you approach? Would you do 2 different stents? Would you do 2 overlapping stents? Or would you do a very long stent, right? And then AI can learn from the experts and try to output that information in a way similar to how we think, and hopefully help physicians who have less experience in intravascular imaging interpretation.
That was excellent. So it appears that we not only we need an Ivan in the labs, but also we need Daniel now to add on top of to add the quality, right? To screen through the images and filter those that should be used, and the rest either discarded or there's so many suboptimal, then maybe repeat the scan. But it's very, very important that we do a fine job, because the input is defining essentially the strategy. And of course, your work goes touches upon the landing zones and stent strategy, essentially, which is very, very pertinent here. And hopefully I can recommend, never replace, but our judgment will recommend in a very expert-based approach what would be the best for this individual stent approach and strategy. So then do you feel that this kind of like effort, this kind of approach of filtering the images is going to essentially replace our clinical judgment?
No, I wouldn't say replace. The vision we have is that we would like to offer clinical expertise from experts in intravascular imaging. It's not going to be Daniel or Evan. Ideally, it would be a large panel of experts that would train the machine. So most of those algorithms that we currently have been trained by engineers, by coders, by clinical scientists, but they don't have the mindset of an interventional cardiologist looking at those images. So they serve the purpose they were made for, which is border tracing and plaque characterization and so on. When it comes down to clinical judgment, we need the experts in imaging interpretation, training the machine. So hopefully the machine will replicate what a panel would do. If I bet that if the 3 of us look at those pullbacks together, we're going to have different opinions. And what the machine will learn is what is the average opinion from this panel of experts. And that, that's how we envision that this can be used, and not only for image quality, but as I showed, for landing zones or for after the stent. It can help us decide on pulse dilatation, on when enough is enough, to accept an optimal or suboptimal result. Right? Sometimes you have focal under expansion, sometimes you have multifocal under expansion, sometimes you have diffuse under expansion. So the strategies change, and you're going to have a panel of experts providing information through AI.
Excellent. So I'm going to now open this to the panel, and we can spend a few minutes here on some discussion on some burning topics here. And I'm going to start with asking each of you, what is your feeling about the next 5 years? Where will we be in the next 5 years in the field of PCI? Of course, assuming that PCI will be still here.
I certainly think, the good news, we very often focus on that the majority of PCI is not done with intravascular imaging. The good news is it's really on the rise. It's growing, multifold each year. Again, going back to the Michigan data, it went from 7% to 25% in a matter of 3 years. So it's growing, it's on the rise. And AI, I think, is going to rapidly accelerate it. And we've seen that in some initial data. And, building on what Daniel's doing and others, is it's making the AI better, because the more the AI can give of this is high quality, this is where we should actually treat it. Because right now the AI is good at some basics. This is the MLA, this is calcium, but it doesn't tell you what to do with that. And there's still that expertise and that's partially why there's some unknowns. And as it gets better and better and we build upon the AI, first of all, I think all the imaging companies, that's just going to be standard of care. And then there will be continues to have advances of incorporating things like an imaging-derived physiology, and that gets integrated into the AI of this is where you should land the stent. So it's not even just the experts, but this is how we could relieve ischemia if you go with a 33 millimeter stent as opposed to a 28 millimeter stent. And I think that's going to help us, one, improve outcomes, two, have it more user-friendly and better, more efficient workflow, and then three, greater imaging adoption.
We can also see AI incorporating prediction models, right? So we're basing our decisions on, the standard way to look at outcomes, the future outcomes. And now we have the chance to incorporate all the imaging features with a more dense cloud of information for clinical outcomes, and incorporate that into AI. That hopefully is going to help us make better decisions.
That's a great point, because actually beyond the cath lab, that's going to influence how long, stents in the US are labeled for a 1 month DAP. Is this a case where I should do 1 month DAP, or is this a high stent thrombosis risk? I'm going to continue this out a year, because, when you have an end result with expansion of X, YZ, you're at a higher risk. And that's going to help us even more than just technically. That prediction model, I think that's going to drive pharmacotherapy.
Yeah. And the technique, for example, if you have a large malposition. So malposition is something that we see a lot in the cath lab. People are usually worried, especially with OCT. It's big, it's color-coded, it's showing there, right? But there's no clinical data relating acute malposition with events, right? We have the chance now to individualize treatment. It's actually a good thing to leave a large and long segment of malposition in an elderly patient where you need to abbreviate that, knowing that this stent is going to take longer to heal. So these are unknown questions that we have an opportunity to incorporate clinical data and into prediction models and try to individualize the way we treat and how we optimize results. I see we changing a lot the way we practice with incorporation and advancement of AI.
Only if you know, you can understand better and then change. So, Dr. Alsharqi, let me ask a provocative question to you now. Dr. Shlofmitz and Dr. Chamié, they are very esteemed interventional cardiologists who believe that the future is bright, more intracoronary imaging, and I'm sure you understand where I'm going with this emphasis, intracoronary imaging. So more emphasis on intracoronary imaging, AI in the years to come. The question is, will there be intracoronary imaging or non-invasive CT planned and guided PCI within the next 5 years?
Well, this is really interesting question, and I don't want you to feel bad by saying non-invasive would be being moving forward in the future. But I believe that with AI in the future, it can not only add precision or quantification, but also it can be like a means to fuse and link all these modalities together. Like when we do IVUS, we need non-invasive CT scan at the beginning. So these modalities work together. And especially with the production models, we in research, we're really pushing hard towards creating production models, and especially at the in the era of generative AI, when we have data disparities for this specific group of patients, we don't have enough data to have insights and associations and to develop these models. So we generate and synthesize data for those patients to make more meaningful and clinically insightful outcomes. So I think, again, by understanding how AI works, and in the future, we aim to accelerate medicine with AI rather than replacing what's available.
Everything is complementary here, and we need non-invasive imaging, invasive imaging. We need AI to help us be more kind of efficient and faster and more precise with any kind of imaging we use. That was a great discussion. I think that 3 amazing papers. Thank you so much on behalf of everybody here and the editors of the issue for your effort to contribute your innovative and fresh spirit to this issue. Thank you so much for the discussion tonight. I found this very refreshing, very exciting. I believe this recorded kind of discussion should be kept in the records, and I'm sure that we have to see it again in 5 years and see how prophetic we were. But I saw great forward-thinking viewpoints tonight, and I'm sure that not many at this point will necessarily agree, or maybe we think that we're too forward-thinking, but I believe that it's a reality. It's the immediate future, and the best thing to do is to be ready to follow this immediate future versus staying outdated and rigid and stubborn on old school practices. Thank you so much for your discussions tonight, and I look forward to seeing you around. Thank you so much. It was great.